Welcome and thank you for joining the Lake Superior Quality Innovation Network responsible opioid prescribing for high-risk patients. Ms. Gloria Pizzo will now begin.
Good afternoon and welcome to today's webinar presented by Lake Superior Quality Innovation Network in partnership with Macomb County Community Mental Health. Today's webinar is paid for by a State of Michigan Health Innovation Grant. The Lake Superior Quality Innovation Network is comprised of three organizations: MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. And now I'd like to introduce today's speaker, Dr. Scott Fishman. Dr. Fishman is a professor, Chief of the Division of Pain Medicine, and Executive Vice Chair for the Department of Anesthesiology and Pain Medicine at the University of California, Davis Medical Group. Dr. Fishman lectures on all aspects of pain control, including preventing prescription drug abuse. He has authored many peer-reviewed articles in medical journals, book chapters, and other scholarly reviews. He is the senior editor of the journal Pain Medicine and serves on the editorial boards of other medical journals. Dr. Fishman advocates for the safe use of pain medicines with consumers and lawmakers and has served on many boards of directors, including the Academy of Pain Medicine, American Pain Foundation, and the American Pain Society. Prior to his current role, Dr. Fishman served as medical director of the Massachusetts General Hospital Pain Center and Harvard Medical Center. And at this time, I would like to turn it over to Dr. Fishman.
Well, hello, everyone. I think good morning, but maybe good afternoon for some of you. The topic today is responsible opioid prescribing, and I'm going to be covering a lot of territory. My goal today is to give you a sense of what the regulators and authorities expect of our practice when we're using opioids and give you a little background on the prescription drug abuse problem. I'll be moving pretty quickly through the ladder through the prescription opioid problem because I suspect most of you are aware of it. These are my disclosures. No financial relationships with drug companies, industry, speakers, bureaus, consultation programs. I receive royalties from books, etc. I wrote a book for the Federation of State Medical Boards called Responsible Opioid Prescribing. This is the overarching body of medical boards in the U.S. Past president of the Academy of Pain Medicine, chair of the board for the American Pain Foundation, and past chair of the Pain Care Coalition. And mostly I want to say I'm not a lawyer and don't offer legal advice. The problem today is that we have a problem of inadequate pain relief in America. We have the Institute of Medicine citing that we have 100 million Americans in chronic pain, and yet some say we undertreat pain. The statistics would not support this. This is a statement from Nora Volkow, who's the director of NIDA, and she said prescriptions for opiates have escalated from around 30 million in 1991 to nearly 180 million in 2007, with the U.S. the biggest consumer. The U.S. has supplied 99% of the world total for hydrocodone and 71% for Oxycontin. So as you can see, we use most of the world's opioids. It's estimated we use about 80% of the world's volume of opioids. 99% of hydrocodone, which you know is just recently rescheduled as a Schedule II drug. And the bottom line is that opioids work for some people and not for everyone. They are ineffective for some pain, and they're very problematic for some people, and it's hard to tell the difference at the beginning of treatment sometimes. The bottom line is when we use these drugs for chronic pain, the data on the benefits is not established. Many think that there's good science on efficacy for these drugs. The fact is that most people who choose them are choosing them because they're the option of last resort. Unfortunately, we prescribe them so excessively that some have suggested that we're using them as the option of first resort, which is problematic, particularly because the data of risk is so clear and convincing. The data on risk is very strong and clearly shows us that risk goes up with dose. This was brought forward in October 2014 by the Agency for Healthcare Research and Quality, which found that the evidence on long-term opioid therapy for chronic pain is very limited and suggests increased risk of serious harms that appear to be dose-dependent, as I just said. The President, the White House has said we have an epidemic of prescription drug abuse. It's all over the media. Unintended overdose deaths from opioids exceeds motor vehicle accidents in most states in the United States, and on average is the leading cause of accidental death, which is shocking. And we have practices that are really pill mills that exist simply to get abusable drugs to people who can pay with cash. These are criminal practices. They're probably rare. They're not rare enough, and if you're interested, there's a very good documentary called the Oxycontin Express that can be seen on the online. All you'd have to do is Google Oxycontin Express, and you'll find it but it's from the Current TV online station. This graph here gives you a sense of what the regulators are looking at, and that is that if you look at the turn of the century in 1999, opioids were commingled with cocaine, heroin, and other drugs that were commonly part of unintended overdose deaths. But as the new century proceeded, and up until today, so this could go to 2015, what we see is that opioids broke away, and there was a steep rise in opioid-related unintended overdose deaths. If you ask yourself where these opioids are coming from, the best data we have is from the Department of Health and Human Services and the Substance Abuse Mental Health Agency in the Department of Health and Human Services. And what they show here, and this is a complicated slide, but what it shows is that most patients who are involved in unintended overdose deaths or non-medical use of opioids are getting their medicine in one way or the other through one physician, either through a friend who got it from a physician, a relative, someone who bought it off of someone who got it from a physician, etc. And that's really the bottom line with this graphic. This is an important graphic, which on the left shows you essentially all patients who are using opioids for chronic pain. This is data from the CDC. And what they show is that most patients on chronic opioids are in that green zone where they're seeing one doctor and they're on low dose. A minority of patients are either on high dose or seeing more than one doctor. But if you look at the patients who ultimately overdose, you can see very clearly that the majority of those patients are either on high dose or seeing multiple doctors, or in fact both. A very interesting, important statistic. We're seeing this problem in adolescents as well as and children, not just adults. We have a problem of newborns being born in withdrawal. We had a problem just here in Sacramento where I am, where a breastfeeding mother who was a drug abuser delivered drugs she was abusing through breast milk to a child, 8-month-old boy who died. A very, very sad story. In terms of the data, these are some of the studies that our regulators are looking at. This is a study from West Virginia that showed that over the year 2006, they had about a little less than 300 decedents from unintended overdose deaths. This was the state that had the most overdose deaths related to opioids in the years prior to this study. What they showed is that most of these overdose deaths were actually related to the drug methadone, and we'll talk more about that if we have time. The doctor shoppers, the patients who were getting drugs from multiple doctors and multiple pharmacies were largely older females, and the diverters were largely younger males. As I said, methadone was the most attributed opioid. 95% of these folks had indicators of substance abuse, which suggests that if we screen, we might be able to target these folks before harm occurs. 66% of these folks who had unintended overdose deaths didn't have prescriptions for the opioid that was found in their body. And I'm not sure if that's more alarming than the fact that 34% overdosed on drugs that they were in fact prescribed. Washington State took a little different tack. They looked at about a little less than 10,000, a cohort of about 10,000 people with 3 or more opioid prescriptions within a 90-day period, theoretically with using these medicines for chronic pain. And what they found is that if the daily amount of opioid was greater than 100 milligrams per day, these folks had a 9-time increased risk of overdose. This data has been questioned, but even if it's 6 times or 15 times, it's striking data that gets attention. The problem is addiction, abuse, and aberrant behavior in these patients when we prescribe to them. It's important to understand that addiction is a different disease than some forms of abuse and some forms of aberrant behavior, but all of those entities are problematic in a patient in pain. And it's important to be able to distinguish addiction from pain. So I want to make it clear that addiction is defined by most groups that define it as essentially drug addiction is the compulsive use of a drug that produces harm and the continued use despite that harm. I would translate that to the compulsive use of a drug that produces dysfunction and the continued use despite that dysfunction, because I make that distinction largely because it's important when you're talking to someone in pain to look at their function. And the reason for that is that if pain relief is the only outcome, is the only assessment point that we have for pain, and pain relief is the only outcome, I would argue that your outcome is going to be untestable. And most of the regulators argue that now as well, but they want you to have objective outcomes. And you should ask yourself, if someone comes to you and says, I have pain, but it doesn't interfere with any part of my life, is that pain that's worth taking a lot of risk to treat? This is why we ask the question. I can't prove that anyone does or doesn't have pain, and I can't prove that anyone does or doesn't have pain relief. But I can prove that someone came to me and said, I have pain, I can't work, I can't sleep, I can't be with my children, I can't go to my church, I can't do things that are meaningful or important in my life. And after treatment, those behaviors have changed. That's provable, and that's up to you to determine. Patients who are addicted to medications and abusing medications rarely improve their function with those meds. In fact, the definition of addiction typically hinges on the unmodulated use of a substance that produces harm and dysfunction. So that's diametrically the opposite of the outcome we're looking for pain. This is really a key teaching point, a paradigm change, and something that our regulators are looking for. So on this slide it says patients with addiction take increasing amounts of abusable drugs and function does not improve. Patients with analgesia usually find a stable and usually a moderate amount of the drug with improved quality of life, which is demonstrable through functional outcomes. And you get to choose those. We typically ask these patients, what is it that you want to do with treatment that you can't do now? And again, if the answer is nothing, we still believe them and we still treat them, but we don't give them life-threatening treatment. And if the answer is, I want to do A, B, and C, the question is, are they realistic? And once you have realistic outcomes, you target them and tailor your therapy to them and come back to them in follow-up with your treatment. So this is the paradigm shift that I mentioned. A lot of doctors are getting into hot water because they're not following these guidelines. I won't go into detail about this. I just put on here a case that was in California a couple of years ago where a California doctor was faced with an addict that had been wired by the feds. He brought in fake records, and the physician gave the patient anything he wanted. And the images that were brought in, many of you may see the telltale sign here. This is actually an X-ray of a dog. This clinician was charged and prosecuted criminally as a drug dealer. So what are the standards that we're asked to meet? Well, this is the model policy from the Federation of State Medical Boards. It's the policy that I based the book that I wrote for them on. It was recently revised in 2013. and I want to run through this because this is not necessarily a guide for physicians. It's a guide for medical boards on what to look at in physician practices if your practice were to be challenged or reviewed. So the bottom line is physicians have a responsibility to minimize the potential for abuse and diversion, and physicians may deviate from recommended treatment steps based on good cause. This is what the policy says, that it's clear that the state medical board will consider inappropriate management of pain, particularly chronic pain, to be a departure from accepted best clinical practices, including but not limited to inadequate attention to initial assessment to determine if opioids are clinically indicated and to determine risks associated with their use in a particular individual. Inadequate monitoring during the use of potentially abusable meds. Inadequate attention to patient education and informed consent. Unjustified dose escalation without adequate attention to risk or alternative treatment, and excessive reliance on opioids, particularly high-dose opioids, for chronic pain management, and not making use of available tools for risk mitigation. The risk mitigation typically relates to using your prescription drug monitoring system and urine toxicology screening. So in a nutshell, and this is a policy that's probably 30 pages that you could read. I would suggest every health system help their clinicians by incorporating these policies into your local policies. But essentially, what the board wants to see is that if you're going to treat pain, you understand it. We see clinicians argue that, hey, I prescribed something inappropriate because I didn't really know. Well, it's expected that you know, and hopefully we'll do a better job teaching medical students how to assess and treat pain and use controlled substances in the future. But for now, it's imperative that if you're going to treat pain, you know, you understand how to assess it and what you're dealing with, and then you evaluate patients fully for the best diagnosis and the best treatment, including stratifying the risk for any of the treatments, particularly opioids. Develop a treatment plan and goals that's documented. I can't tell you how many times I see cases where this is not the case. Get real informed consent and an agreement to treat. This is where a lot of doctors say, I don't have enough time. Well, the bottom line is that it's assumed anytime we do anything to anybody, anywhere, that we have informed consent and an agreement to treat. The issue for you is just how much you want to codify it. Initiate a trial, which means start low, go slow, and watch what you're doing. And you may see that this drug doesn't work, or you may see that it works at a low dose, etc. But just don't commit the patient to a lifetime of treatment. Try it out first. Don't just try it out willy-nilly. But if you're going to try it, a trial means that you will come back and reassess whether the medication met your target outcomes. Ongoing monitoring and adapting the treatment plan means that when you do come back, you respond to the information that you find and you adjust. Periodic drug testing is self-evident. Consultation and referral when the patient's problem is outside of your purview of expertise. Consider discontinuing opioid therapy. I would argue don't start if you can't stop, and have an exit plan before you start, meaning know how you're going to make decisions about when to stop and how you're going to do it, and I would share that with the patient up front. The Substance Abuse and Mental Health Administration of the Department of Health and Human Services came out with an overdose toolkit that I think is useful for any practice. These are the recommendations for patients, loved ones, community members, and prescribers. They state that at the time a drug is prescribed, patients should be informed that it's illegal to sell, give away, or otherwise share their medication. We would think that that's self-evident, but evidence suggests we need to tell patients this, and that it is their obligation to keep the medicine in a locked cabinet or otherwise restricting access to it and safely disposing of unused supplies. These are the recommendations that they want to encourage prescribers or people at high risk to learn how to prevent and manage overdose. Ensure access to treatment for individuals who are misusing and are addicted to opioids or with other substance abuse disorders. ensure ready access to naloxone is actually probably the number one way they encourage people at risk to prevent and manage naloxone. So to manage overdose. Getting them into treatment in advance is the way to prevent it, but managing the overdose is with naloxone that's been shown to be effective at the point of care. We encourage people to dial 911 and encourage prescribers to use the prescription drug monitoring program. So going back to naloxone, there's been good evidence that intranasal naloxone at the time of an overdose can save lives. And there's a recently approved, FDA-approved product that's an auto-injector of naloxone that works very much like an EpiPen. It's on the lower right-hand corner of your slide. I suspect over the next few years you're going to see that widely distributed with people on opioids, particularly individuals at risk or individuals on high dose. The key is that it needs to be used, and sometimes individuals wait too long at home to use it, so it requires some education. You may know that the FDA relabeled opioids in 2013 for the extended release, long-acting opioids for chronic pain. The labeling change is very consistent with what I've described to you already, that chronic use of extended release opioids should not be on an as-needed basis. They should be used after less potentially harmful treatments, addictive treatments, treatments in which there was a better benefit to risk assessment have been considered or tried, and they need to be used with pain severe enough to warrant the risk. And they highlight the neonatal opioid withdrawal syndrome, which I had noted that we have an epidemic of babies being born in withdrawal. Also requiring pharmaceutical companies to pay for post-marketing studies. Unfortunately, this slide got mixed up here, but what it says in the back is there any good reason why hydrocodone should be a Schedule 3 drug? It was recently moved to a Schedule 2. I've advocated for that change for years, and I'm glad it's happened. Most of my primary care doctors are glad it's happened. The bottom line is that the scheduling for opioids is based on abuse risk, and there's solid evidence that hydrocodone has at least as much abuse risk as all the other Schedule belong to Schedule 2, even though it may be harder to prescribe it. Of all the opioids that's prescribed for pain in the U.S., methadone accounts for 2% of that quantity, yet it also accounts for 30% of the opioid overdose deaths in America. The reason for this is that methadone is metabolically less stable than other opioids. It has different T450 clearance and therefore different drug interactions than other opioids. It has high protein binding, which makes it labile with other drugs. It is cleared by, the minority is cleared by the kidney, but if the urine pH changes, all of that drug can go back into circulation. And as you know, it has a black box warning for arrhythmias. So it's a dangerous drug. It has a different analgesic half-life than clearance half-life. Its analgesic half-life is only 6 to 8 hours, whereas its clearance half-life is 20 to 40, even 20 to 60 hours. And therefore it has a high potential for accumulation. I've heard some doctors say that they like to use methadone because it's used in addicts, therefore they think it's safer. It turns out that methadone is abusable just like other opioids, and there's a HBO documentary that talks about addicts preferring methadone over other opioids, even over heroin. Buprenorphine is a newer opioid, particularly newer to the clinical arena. It's a partial agonist. It's been used instead of methadone for maintenance. We thought it might be helpful for pain. We're finding that it has its own abuse liability, and these are some articles from the New York Times showing that, number one, it has some problems with addiction treatment, but it's abused. This is the top articles are actually coloring book pictures that are sent into prisoners from children laced with buprenorphine. So clearly an abusable drug. So the question is, why do we why do we use so much opioid? Where does this practice of using excessive amounts of opioids come from? This is actually an article from Forbes, 2013, about an ER doc who raised his patient satisfaction scores by just giving out more Dilaudid. And this problem isn't new. This is Harper's Bazaar cartoon from 1856, which is labeled Opium the Poor Child's Nurse. We've been excessively using these drugs for inappropriate purposes for a long time. So I'd like to talk a little bit about at least my view of how we got here, and I'll be interested in your views on this in the questions and answers. In the 80s, we recognized, actually we should go back to the 70s, we recognized that cancer patients were suffering, and it was hard to bring opioids bear on their suffering. And then in the 80s, I think we increased the amount of opioid we used with cancer patients, and we found that it greatly improved their quality of life. It was quality of life saving, even though it didn't affect their quantity of life. I think everyone was very excited about this. It's a very humane use of opioids. However, I think we overinterpreted the data on risk in using these opioids during that time, and we extrapolated our results with cancer patients to patients with chronic illness inappropriately. I think that's one of the big problems that we face in using opioids in chronic pain, is that chronic pain patients have much more relevant risks than patients with cancer who are dying in terminal illness. And they're much more complicated cases in terms of balancing the benefits versus the risks of opioids. On top of that, we have very limited resources as clinicians in terms of giving patients what they really need for their pain and keeping them safe with these drugs. One of the factors they need the most is time in evaluation, time in education, and time in partnering with them and treating their pain. And very few of us have that time, and many find it much easier to simply write a prescription. Patient satisfaction is now a more prevalent entity than it's ever been, and that Forbes article describes how it might motivate physician behavior in an unintended way. Most of us have had very little education on pain management, on pain assessment, pain treatment, and particularly appropriate uses of controlled substances. There has been a great deal of concern out there about influence from the pharmaceutical industry, which I think is going to be looked at very, very closely in the future. I see that influence across all of our practices, so I'd be interested to see how much of that is disproportionate in the pain problem. And then the truth is there are some prescribers who are crooks. There are prescribers who are practicing outside the bounds of medicine criminally in these pill mills. I don't think there are many, but they get a lot of attention when they're exposed. So I'm going to spend a few minutes concluding here and really emphasizing what I think is important for you to know about what your regulators will be looking at in your practices. Number one, I think you know that every medical decision has to be based on a risk, on a benefit to risk analysis. And if the benefits don't outweigh the risk, we shouldn't proceed. The beginning of my talk, I emphasized the point that the benefits of long-term opioid use for chronic pain is weak to inadequate. It is not strong. It hasn't changed over the years. What has changed over the recent past is the evidence on risk. And the evidence on risk is clear, convincing, and shows that risk goes up the dose. So, with that change, our decisions need to change. We need to be considering a different analysis. Well, really, I should say the same analysis, but different hinging points within that analysis. Benefits are unchanged. Risks are increasing. The outcome of the analysis must change. And that analysis has to be done again and again every time the dose changes, whether it goes up or down. So that is what our authorities, our regulators will be looking at. If you're going to do this and you're going to prescribe these drugs chronically, I think it's critically important that you prepare in advance, because the risks of not meeting our responsibilities are great, if not almost assured, if we don't prepare in advance to cover all this ground. We need to use opioids for chronic non-cancer pain only when safer options have failed and when we can show that the benefits outweigh the risks. Opioids shouldn't be the mainstay of treatment. That means that opioids can't be the only thing that are being used to mitigate a patient's pain who's in chronic pain. I've never met a patient who didn't need help with conditioning, with support, with other aspects of their pain that opioids not only don't help, but may even worsen. And you need to have clear objective treatment outcomes or endpoints. These have to be discernible outcomes that are typically functional. Many prescribers see this as a very difficult task. I would argue that you just ask that question at the beginning: what is it that you need to do with this treatment that you can't do now? And you follow those. And as you treat, you ask, what can you do with this treatment that you couldn't do before? And again, you assess the patient before you prescribe for risks, and you assess them again for those risks every time you look at them and you manage them. I review cases across the country, and I see doctors who do far better risk management when your patients are on ibuprofen and Tylenol. They would never let that patient go without liver function testing or renal function testing. But we put people on opioids and we just set them and forget them, and we let them go on, and we never ask the question, are you actually better? And define better by increased quality of life through functional gains. We need to get real informed consent. That means informed consent that's really based on a patient being educated about the fact that the benefits don't outweigh, that the benefits aren't proven by science, that the risks are significant with dose, and that we need to weigh those risks against the uncertain benefits. Patients often say they didn't understand it, and then you say they wouldn't have made the choice. They need to know that addiction, abuse, chemical coping, and other problems associated with opioids are not uncommon, that some patients have difficulty discontinuing therapy, that some pain doesn't get better and worsen with opioids. And we frequently in our pain center see patients who are on very high doses of opioids who weren't better at a quarter of the dose, let alone half or the full dose. And when we get these patients off of their opioids, they are in fact better. And I would argue even if their pain is the same, they're better by virtue of the fact that they're no different, except that they're facing far less risk. Their risk profile has been significantly diminished. Taking other substances that decrease respiratory drive is very, very serious, and I want to emphasize this point, that unintended overdose death risk goes up dramatically when you have additive respiratory depressants. So we argue that you should never have any other respiratory depressants on board with chronic opioid therapy, particularly maybe true for all opioid therapy. And the main culprits are benzodiazepines and alcohol, but there are other agents that you need to think of as well. And as I said, screen for risk before prescribing. The risks go up with any kind of mental disorders, respiratory disorders like COPD, CHF. Sleep apnea is a major problem. I suspect we'll be screening patients for sleep apnea much more than we are. We screen every patient here for sleep apnea in our clinic who is using opioids or any respiratory depressant. Substance abuse is clearly a risk. Renal or liver dysfunction and clearance problems are also a risk. As I said, risks increase with dose, and they particularly increase with concomitant use of respiratory depressants. Never increase opioid the opioid dose just because you have no other options. I see this happen all the time in primary care offices, emergency rooms, etc. And don't prescribe if you're not willing or able to stop, and have a plan for stopping before you start. That requires having clear functional expectations, having a plan for how you're going to assess the patient over time, having clear limits, and if the drug's not working, have a plan for how it's going to be tapered off with an agreement on that before you start. And then, as I said, one of the newer expectations of our regulators is that when they look at your practice, your patients aren't just on opioids, because then they start wondering, are you just taking the path of least resistance and just giving them a prescription, as opposed to giving them really the multifactorial treatment that we know these patients need and is really required to get solid benefit from a pain management plan. In order to achieve this, we're required to educate our patients, and I really want to drive this point home, and that education takes time. As I said, you got to prepare in advance, and much of this is not going to occur at the bedside. You probably need a process where your patients can learn about safe use, storage, disposal, pregnancy, driving issues, etc. And I'm going to end with the recommendations from a late 2012 summit that occurred in Washington State, which I thought came out with very, very clear and common sense recommendations for prescribers and patients. And that is that, and these are 3 slides, and then I'll finish and open up to the group, that self-care is the foundation for effective chronic pain care. So essentially, our goal should be to help the patient take care of themselves. Our relationship with the patient supports effective self-care. Excuse me, big sneeze here. Thank you. Excuse me. Guides your care by progress towards resuming activities and prioritize long-term effectiveness over short-term pain relief. Put patient safety first. Think twice before prescribing long-term opioids for axial low back pain, headache, and fibromyalgia. These are disorders where there is considerable consensus that opioids, in fact, don't improve quality of life for most of these patients, and many it worsens their quality of life. So we really got to think carefully about that population. I would say that the analysis that goes into these populations really is the same that should go with any patient that we would put on a chronic opioid. And in any patient we put on a chronic opioid, we need to think about their risks and evaluate the risks. And you consider intermittent use of opioids. Typically, most of us put patients on an opioid with the idea that they're going to stay on daily doses almost for the rest of their lives. You might think about only using opioids intermittently when the pain is most severe, and then keep the dose as low as possible. Anytime the dose goes up, understand that risk goes up, and the benefit to risk analysis changes. It needs to be reconsidered, and we need to, if the dose does go up and there are not clear discernible benefits, we need to go back down to that dose level where the patient had the same pain relief but less risk. These are principles that are true of prescribing with any medication. Clearly communicate standardized expectations to reduce risk. Adhere to recommended precautions. Avoid prescribing opioids and sedatives concurrently. Revisit discontinuing opioids for lowering the dose. This is a conversation that needs to happen on almost every visit. The question needs to be asked, is it worth taking this risk? And if the patient's having side effects, particularly without clear functional benefit, the question is, would they be more functional off the opioid? Even if they have pain relief and their function is diminished, would they actually be better with more pain and greater function? These are questions that are worth asking and answering. And then identify and treat prescription opioid misuse disorders. This is a very important area that you're going to be hearing a lot more about. The problem is that many of us don't have treatment for prescription opioid misuse disorders available for many of our patients. It's hard to find addiction specialists or resources to help us, and this is a shame and something that has to change. So the bottom line here is that you're expected, if you're using controlled substances, I'd argue even if you're using non-controlled substances, to evaluate efficacy and risk and do a analysis of the benefits to the risk. The benefits must outweigh the risk, and in my experience, they often don't. And the fact that the patient either put on the opioid or continued on the opioid is simply that the analysis is frankly never done. So I hope that helps with some, kind of a high-level overview. And with that, I'm going to stop. My email is on this slide, and I think you'll have opportunities to get my slides in other ways. But if you want to send me an email, I'd be happy to send you a PDF of my slides. And with that, I really thank you for your attention, and I look forward to your comments and questions.
Ashlyn, could you please open up for Q&A?
Yes, ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And we have no questions in queue at this time.
While we wait for some Q&As to come in, the evaluation has been pulled up. If you would please complete the evaluation, take a moment to let us know how we did by filling these out. I appreciate that. Thank you.
And we do have a question in queue at this time from Leonard from Oakland County Mental Health.
What's the email address to get the slide?
Okay, the email address is S as in Sam, M as in Mary, Fishman at ucdavis.edu.
And there are no more questions at this time.
We'll wait for a couple more moments. Thank you. Dr. Fishman, this is Gloria. What other treatment assessments or goals would you have in mind for some patients that are on opiates and that have addiction problems?
Well, patients who have addiction problems are a special group that, again, the assessment is the same. If we're looking at benefits versus risk, the benefits are unclear, but in a patient with addiction, the risks are far higher than a normal patient. So you've got to be able to really clearly make the case that a patient with addiction who giving opioids might stimulate a life-threatening addiction problem is worth that adventure. I would say it would be the very, very, very rare case where you can make that case. And just as I said about the guidelines from medical boards and other regulators requiring that you get consultation when you have a patient whose problem is outside the purview of your expertise. Unless you're an expert in treating patients with addiction and have the resources to keep them safe, you're really obliged to have a patient like that managed by someone with that expertise, and very few of us can find it. So that's a patient population that's very rarely going to meet criteria for giving an opioid, and if they are, you have to have an assessment plan to make sure that they are sober, that they're not abusing. You need to trust but verify that they're not abusing, and you need to keep them in a milieu that keeps them safe. So most of us don't have those resources. There are rare cases in which some pain patients have those resources and can get that kind of treatment, but at that point you're looking at very high-level evaluation that they are not abusing drugs and that their function is improving. It's the same kind of assessment, but at a very, very high-risk level. I think today with the data that we have, it would be the very rare case of a patient that truly has an opioid addiction problem who would meet a threshold of evaluation for chronic opioid therapy. I hope that answers your question.
Yes, thank you. Now, I have another question for you. So for instance, it's not a opioid-addicted person. What other alternate modalities would you suggest for those that are on opiates versus just pain medications?
Well, first, there are pain medications that are not opioids that can be tried. So there are many, many other analgesics. But when someone has pain, there are so many choices. I don't have time to go through all of them. We could spend a couple hours just doing a high-level review of all the options for pain management. But, it's a mind-body problem. And when I was first starting in this field, I used to try to convince my patients that I didn't think their pain was in their head because they were all worried that that's what we would think, until I realized that you can't have pain without a head and that the head's part of it. And really, the answer to your question is looking at the patient as a whole person. As I said during my talk, one of the questions I always ask of a patient in pain is, what is it that the pain impairs you from doing? How does it impact your quality of life? If it doesn't, I'm still willing to treat it, but I will look at it differently in terms of how much risk to take. So that's my first step. The second is, how much of the pain, where is the pain? How can we treat it? Is there a way to treat it locally? For instance, a patient that comes to me with pain shooting down the back of their leg and the distribution of the S1 nerve, I'm going to do a spinal injection on that patient. I'm going to put some steroid on the hot nerve root if that's in fact the problem. If they come to me with burning in their feet and their fingers with a neuropathy, I'm going to use neuropathic analgesics, not opioids. If they come to me with a problem that is caused by deconditioning or because of the primary pain, they've been inactive and have secondary deconditioning, I'm going to recondition them through physical and probably psychological therapies. And if their pain's amplified because they're anxious about it, they're fearful, they're having insomnia, etc., these are all known amplifiers of pain. I'm going to treat those directly. So unless you gave me a case that I could be very specific about, there are so many choices for patients in pain and how to treat them that I couldn't give you a generic list. But I think the regulators want you to know what that is and consider those options and even try them. Now, I've rarely met a patient in chronic pain that doesn't need a careful exercise program and doesn't need some psychological resources, even support, let alone mindful meditation, hypnosis, etc. We've known for thousands of years that these are potent interventions for pain. We know that there are many mild drugs that can treat pain, etc. There are other treatments. The problem is that we may want to try these for patients, but they're not covered by their insurance. So I'm hoping that in the era of value-based care and accountable care, that we'll actually shift towards embracing these, actually cost-efficient treatments in terms of reimbursements. But a lot of doctors are frustrated that they can't get their patient into good physical therapy, into psychological counseling. They can't get them seen by a physiatrist who might be able to do a conditioning program for them, etc. And can't get them the other meds that might be less risky than the opioids, and then just give up and give them opioids. That won't be a tolerable practice according to our regulators. So I hope that answers your question.
It did. Thank you so much. Ashley, are there any other questions?
Yes, we do have a question from Pam from Health Service Advisory. Pam, please go ahead.
Sorry.
Pam, you're live.
Yeah, I had it on mute. Sorry. Just can you give some guidance to how a hospital is supposed to deal with a patient that is on chronic opioids and they are admitted to the hospital and the hospitalist is taking care of this patient, and it could even be a sickle cell patient. It can be someone, that has chronic pain, but they do have the 5-star, quality measures now that they have to meet. So how can they deal with this?
So I think hospitalists are really looking at a patient in a fairly finite period of time in an acute care setting. So, hospitalists need to prescribe using the same principles that anyone would prescribe, but then, you have to work with, the hospitalist is going to have to work with the prescribers as well. If you don't feel the opioids are positively contributing, you can assess, document, and talk to the prescriber. And even during a hospital admission, you can start a taper. The problem is that often the hospitalist is seeing the patient in crisis, in which case it's probably not a period that you can get an assessment of what the patient is like during non-crisis periods. So you're in a difficult position where you just have to do the best that you can for that time. Often you may need to raise your concerns but maintain the drug because there's greater harm in reducing or removing that drug during that short period of time. But I wouldn't hesitate to assess and deliver your assessment to the prescribers who have to make those decisions chronically. Patients in sickle cell crisis are a whole other story, and that's something we don't have time to go into detail about. But they're patients who really need to be looked at globally and really look at what the nature of the crisis is. But they're in real acute pain crises. Often they're on so much opioid that they're opioid insensitive, if not have hyperalgesia. And just giving them more and more opioid doesn't actually treat their pain. It just dissociates them from their pain. So there are many, many other options in that setting as well, other than opioids or in addition to opioids that have to be considered. But that's a difficult setting. So, I think the key is to understand that you're doing the same evaluation, but it's in a different setting of acute care, and it's usually very, very brief. Hope that answers your question.
It did. Thank you.
We have another question from Shirley from Lutheran.
Can you hear me?
Yes, you're live.
I have just a brief question talking in terms of geriatrics and for the patient that can't speak to you and has chronic pain. Because we fall into a lot of quandaries because we come from the hospital on Haldol, Ativan. We have to take them off immediately upon admission. And then we start doing our dose reductions even in terms of opioid use. I think we forget about the geriatric could be addicted too, but they can't tell you. And we have behaviors. So the hospital deals with the behavior a little differently than the actual nursing home care. They're more apt to pick that Haldol, pick that Ativan, Xanax, Risperidol, tie them up. And we're basically drying them out the first 48 hours. We have falls. They're at such high risk. But that's how we have to deal with it in the geriatric setting. But I don't know how to approach to try to decipher. And it can take up to a month to figure, is this pain? Is this a behavior? And they can't talk. And we don't use PRNs for that reason because the patient or resident is not able to tell you. What's your suggestion on that?
Well, these are very complex cases, and you set it up with some assumptions that these are what you do. I'm not clear why you do it the way you do it, but you must have good reasons. Obviously, it sounds like you have patients who are coming in on benzodiazepines, opioids, and neuroleptics. And that's a complex array of medicines that need to be used with, great thought and great care. I don't understand why they're on those in the first place, and then why you would take, if there were good reasons and they were working, why you take them away. But, the issue here is you have a nonverbal patient. We have patients who are nonverbal all the time, and there are nonverbal ways to deal with patients. There's a literature on this. There are assessment tools for nonverbal patients in pain. The American Geriatric Society has very good ones. You can look to their website. If you just Google the topic, you find a lot on this. There's been a great deal written on it. But it is a problem. You had said that some of these patients are already addicted to opioids. I would have to wonder how that would be. Maybe they became addicted, but addiction is, as I said, a compulsive use of a drug, and it seems like there's no control that these folks have. Now, they may be tolerant, they may be dependent, and you have to be careful about that. Tolerance means that the drug wears off over time and you need more and more to get the same effect. Dependence means if you take them off suddenly, they'll have a withdrawal response. So you need to be careful. The drug you want to be the most careful with, I think, of the three that you noted that you take away, is the benzo. That's the one that can really cause the life-threatening withdrawal, although in geriatric patients, the cardiac effects of withdrawal of any drug can be significant. This is a very, very difficult population, and you have to deal with them with care and a great deal of thought. So I can't give you a specific cookie-cutter algorithm. Other than, this is a tough population that can be dealt with appropriately, humanely, but you need to really think about what you're doing, and you're coming in kind of behind the eight ball when they come in with so many drugs on board. I hope that helps.
Thank you.
And there are no further questions in the queue at this time.
No, thank you. We are about a minute up before the hour, and we'll end it at that. And thank you for joining our webinar today on responsible opioid prescribing for high-risk patients. Again, if you are in need of the slides, you can email Dr. Fishman at smfishman@usdavis.edu. Thank you, and enjoy your day.
That wasn't correct.
Go ahead, Dr. Fishman.
It's SM Fishman at UC Davis.
Oh, I see that. Okay. I apologize.
That works. Thank you all.
Thank you.